achieved. So whether other agents should be used to improve hemoglobin, or splenectomy would be advised in such a patient. So this is the case 2B. This is the sibling of the child we discussed just before. So she is currently 9 years old, and she has been diagnosed as a case of non-transfusion dependent thalassemia along with his brother at the age of 8 years, and she has a moderate anemia and the spleen which is just palpable, and she has been started on hydroxyurea therapy from last year 2023 and has never needed a transfusion till now. So her growth is around the median with a weight of 29.6 kg and a height of 136.5 centimeters. So she has been started on hydroxyurea, and we have been able to achieve a hemoglobin of 9 gram per cent pre-transfusion. So, and she has she has a very mild minimal hemolytic pacing. So since these are siblings and they have the same genetic mutation in both of them, but they have a variable quite different phenotypic expression. So how can we explain this variability between these two siblings? So case number 3 is a non-transfusion dependent thalassemia with cardiac involvement. So currently she is 9 years of age, and she has been diagnosed at 4 years of age with a massive splenomegaly. She had a short stature and had severe hemolytic pacing, but she was on infrequent transfusions. When she presented to us, she had difficulty in breathing and she had difficulty in climbing stairs. An echocardiogram was done this year in August, where pulmonary hypertension and tricuspid regurgitation was detected with a peak pressure gradient of 30 millimeter mercury. So she has been started on supportive cardiac medication and has been advised regular transfusions. So our question to the eminent teachers, that should we continue to have regular transfusion regimen for this child like we do in case where we want adequate growth in NTDT children, and if so, how long should we continue this?
Thank you, Dr. Sudeepka. So now we'll discuss all these 3 cases towards the end of the session after both our speakers have delivered their lectures. I would request Dr. Lal to start his discussion.
Thank you. I will share my slides here. I appreciate the case presentations very much. I think it really set the stage and just demonstrates both the complexity of presentation and the difficult treatment choices that are only sometimes guided by medical judgment and often by constraining factors. When I have been invited to speak to give a talk in India, I'm very much conscious of the fact that my perspective is from managing a very small group of individuals who have thalassemia. And what I can add to the knowledge that my colleagues have in India is really only if I am able to present the perspective from managing patients in the United States. I trained initially in India, and I was at the PGI Chandigarh. Dr. Marva back in the 80s and early 90s. And so I've had some experience in hematology in India, and subsequently there have been repeated contacts to just to share experiences, and for me often to learn more by these interactions, just like the one today. So I am very thankful for the invitation. So as recently we've in the last 5 years or so, we've been asked by, especially by the Centers for Disease Control, the CDC, to have standardized guidelines because they're concerned about transfusion complications as a whole. And thalassemia is one of those conditions where transfusion complications tend to come to the fore because of the number of transfusions and the duration that they continue for any single individual. The one slide to just demonstrate that we are talking because I'm making some presumptions here, and I apologize if I'm wrong, but because we are talking about predominantly northwestern India. I want to highlight that when we talk about transfusion strategies, we think about 4 broad categories of thalassemia syndromes: the beta thalassemia major, E beta thalassemia, hemoglobin H disease, and alpha thalassemia major. And of those, we're predominantly going to concentrate on beta thalassemia major. I think I'm right based on the cases that were presented today to focus on that. In the beta thalassemia syndromes, worldwide, this is the most common genetic or inherited anemia that's managed with regular transfusions. But the disease or the syndrome itself is pretty diverse. And we've been acutely conscious of this because in the United States, the condition affects mostly the migrant population. And what that leads to is a mix of different pathogenic mutations, and the disease expression is very heterogeneous, just like the cases that were presented. And this really challenges a standardized approach to transfusion therapy. We've been trying to move away from what Mr. Chopra had initially said, that a pre-transfusion hemoglobin and picking a certain number, that probably works for majority, but I think we're moving towards a more personalized approach to transfusion management. Within thalassemia, the introduction of the terms non-transfusion dependent, transfusion dependent has been a mixed experience. The terms were originally devised for the sake of doing clinical trials, and especially for gene therapy and interventions that were potentially very intensive. There was a need to clearly define who was transfusion dependent because only those patients were eligible for the gene therapy trials. But subsequently, it has often become a diagnostic term, and we've kind of, I feel sometimes we moved away from the traditional terms of intermediate and major. But they're overlapping in the sense that many patients with intermediate may eventually start needing transfusions, and they jump from the non-transfusion category to the transfusion-dependent category. And if we place the known the syndromes as we define them clinically, then the beta thalassemia and E beta thalassemia syndromes span a very wide range of needing no transfusions, occasional or regular transfusions. And then there is the category of beta thalassemia major that I'm going to define in a moment. But where do the transfusion goals in thalassemia come from? That's been a difficult issue, and we realize that the science is imperfect, and a lot of the recommendations really come from expert consensus recommendations, and people sharing their experiences and learning from patients. But the goals can be defined in terms of a few different objectives here. First of all, there's the, for example, the management of anemia. So we are seeking in children, we're focusing on activity, growth, the spleen size, the bone health, making sure that the pupil development is on time and there's no cognitive impairment. And for adults, it's all the adult functioning domains in terms of work capacity, personal life, and so on. And as adult patients age, the quality of life and the bone health, for example, become very important issues. And then on the side of the ineffective erythropoiesis, which is the distinctive feature of thalassemia, and sometimes becomes more important than anemia itself. So we have to control the what we call the caloric cost of ineffective erythropoiesis, where the calories or the nutrition is being expended in making ineffective blood instead of growth activity for the child. And extramedullary masses, skeletal deformities, fragile bones, increased iron absorption from diet, or consequences of ineffective erythropoiesis. And then beyond that, I think one of the cases that was presented illustrated that even if you're not achieving the goal hemoglobin, when we start transfusing patients, especially those who have majority fetal hemoglobin, we are replacing part of the blood by hemoglobin A. And that mixture, the change in proportion of F versus A, was expected to improve the oxygen delivery in spite of not hitting the hemoglobin target. So that's the other thing, and it differentiates thalassemia syndromes and the variability of why the same hemoglobin level may be less tolerable in one patient versus another, because hemoglobin is a mixture of different species, and patients with E thalassemia, for example, behave differently at a given hemoglobin level than those who have 80–90% F. The lessons that we've learned are that we have to target both anemia and ineffective erythropoiesis in thalassemia. And sometimes the target hemoglobin that you need for suppressing ineffective erythropoiesis may actually be higher than that needed to alleviate the symptoms of anemia. And this happens in the adult world quite a bit. The people in their 30s or 40s who have hardly ever been transfused in their lives and feel pretty well can come in with massive symptomatic extramedullary masses with neurological complications or some other mass effect that requires urgent attention. So I think we've grown to understand that what's distinctive about the transfusion in thalassemia is our need to pay attention to ineffective erythropoiesis. So there has been some science behind this in the studies that I'm showing here back from the 1990s, this one from Israel, on the effect of, in adults, I think these are in their 20s, who had their resting energy expenditure measured during a transfusion cycle, so before and a week later. And the pre-transfusion hemoglobin was 9.2, and post was 12.4 as a mean of the group. So, and then what you see is that this is the energy expenditure percent of predicted. So 100% is what was expected. And patients had much higher resting energy expenditure when their hemoglobins were in the 9s for the transfusion. And post-transfusion, as the hemoglobin level improved, the energy expenditure fell. And this is the wasteful energy expenditure in some ways, because the anemia requires the heart to work harder, and because the ineffective erythropoiesis is turned on, there's also increased protein turnover, which is of to no utility. So so this gives us some kind of a threshold of what we're looking for in terms of where hemoglobin levels would be from metabolic perspective. But you can also look at one could also look at how well are we suppressing the erythropoiesis, the endogenous erythropoiesis in thalassemia. And for that, there are two measures that were used, and they're essentially linked together. And one could say that maybe serum erythropoietin is probably the best marker for that. And how does that correlate with the pre-transfusion hemoglobin? And then serum transferrin receptor has been was used for, and I think it's still used as a marker how expanded the erythron is in the body. So in both these cases, so if you first looking at the EPO, for example, as the pre-transfusion hemoglobin levels increase, there's a sharp reduction in the serum EPO levels, and you get the moment you go down to less than 9.5 or so, there's a rapid increase, and the same thing happens showing the erythroid activity below 9.5 or so. There's a sharp increase. But what they also, the authors show that there's a pretty wide variability in terms of where an individual patient will fall on that curve. And then finally, also a caution against overtransfusion. And this is a comparison of there was a period of time in thalassemia history when patients in some centers were being kept at a pre-transfusion hemoglobin of almost 12. So here, and then subsequently, they were switched down to a more moderate transfusion regimen. And this figure here is a comparison of blood consumption versus mean pre-transfusion hemoglobin. And when patients were kept at hemoglobins pre-transfusion over 11 or so, their blood consumption was quite significantly higher, by almost 30–40% compared to when that was lowered. So there is an in-between optimal number somewhere, but it may vary from patient group to patient group, if not from any one single individual person. So where do we stand? And then there are other pathophysiological markers like hepcidin and erythroferrone that have also been shown to cycle during the 3 to 4 weeks in between transfusions, to show that, but they have, like the other markers, I think they all basically say the same thing, that there is an inflection point around between 9 and 10, below which all of these things will rapidly increase. So if one looks at these and then tries to answer the question, well, what is a successful transfusion therapy in thalassemia? Then we would, it probably boils down to just saying that this is the reversal of anemia and marrow hyperplasia. So that's the goal, which in children would lead to normal physical appearance, normal growth, and normal activity. And in adults, it leads to normal functioning in both the professional and personal spheres. So that's our guideline for what is success. And the focus of the contemporary management of thalassemia really is health-related quality of life. So we are successful if our patients look, feel, and perform normal. So we went through a phase of trying to identify why we need transfusion goals to be reiterated. And we looked at the studies that have been performed in children and adults. And the thing that has changed, and I just want to make this point, that for a long time, and traditionally even now, we think of thalassemia as a childhood illness or a pediatric illness. And that's actually is not true anymore. You're a child only for the first 18 or first 2 decades of your life, and most patients will be an adult patient for a much longer period of time than they would be as receiving pediatric care. So essentially, the pediatric care is a preparation for our adult patients to have a normal, healthy life of a normal longevity. And the transfusion practices during childhood will affect this long-term prognosis in adults. And that's where the partnership between adult hematology and pediatric hematology becomes critical. The other thing was that, especially in the US, we had to differentiate thalassemia from other anemias, especially sickle cell disease, for example. And to say that the transfusion threshold of 7 to 8 does not apply to thalassemia. It needs its own distinctive transfusion goal. And that we think that there is a problem of underutilization of blood transfusions in thalassemia, so that patients may continue to have symptoms from anemia and marrow hyperplasia. And it's partly because, and it's a personal issue for me, is that when you ask physicians or hematologists, what is the most important problem in thalassemia, they tend to identify iron overload instead of anemia as being the most important problem. And then there is also the concern over donor exposure that can limit the number of units of blood that are used for patients. And but at the same time, we don't want to overreach. And we want to say that the standards for beta thalassemia major are the standards only for beta thalassemia major, and they may not be appropriate for other thalassemia syndromes. So each of those needs individual attention. And then we have to constantly battle with the low expectations by medical professionals for the physical and professional achievements of their patients. And that can be a barrier to optimal transfusion management. I mean, what are we asking for? Well, I know that what we would want is to show a picture like this and challenge people to identify which of these three patients, which of these three is a patient of thalassemia. And taking the theme of iron overload and its concerns one step further, we have been reiterating now that the transfusion plan should not immediately take into account the iron overload that will come with using transfusions. which means that the chelation plan has to be separated from the blood transfusion plan. So that has to be developed based on the patient's needs of where the hemoglobin levels are, what kind of syndrome they have, and whether this presence of spleen, the growth, and all the other factors that come. And then once you have an optimal transfusion plan, then you come in and you devise an iron chelation plan that will support the continued use of an optimal blood transfusion plan. And here I want to just mention that there are certain reasons for these transfusions that are specific to the US at this time. And that, but I have a feeling that there's increased population mobility in India, and then we are going to possibly see something similar to this. And that's because we have a mixed population of beta thalassemia, E beta thalassemia, and alpha thalassemia here. And the other thing is the red cell antigen disparity between donors and recipients, who the donors often tend to be Caucasian, and there are not as many Asian and Middle Eastern people who are donating blood. But we do have an assured availability and safety of blood supply. I think, and that belief in the blood supply has led to us adopting chronic transfusions for symptomatic thalassemia intermedia patients. And I think this is exactly the cases that were presented today. Because the barrier to starting chronic transfusions is much lower in our case because of the resources compared to the number of patients. And then the other issue is the decline of splenectomy. In spleen, you just can't get away from it. It's either you take it out or you don't take it out. And I think that the overall trend has been that splenectomy has declined as a methodology to manage thalassemia. And we have recognized that the reason spleen gets bigger is because the hemoglobin levels are kept low. But if you did keep the hemoglobins high, then the spleen will decrease in size. So in these cases, aiming for lower hemoglobin or not transfusing a patient can be counterproductive. And I think I have one of my patients that we followed here, where was initially thought of as a thalassemia intermedia, and still thalassemia intermedia by its definition, who maintained a hemoglobin around 7 or just below 7 for a long time. And then the spleen suddenly started to get bigger. It's shown in the dotted line, and then started on transfusions here, and then the spleen came down in size. So essentially, progressive splenomegaly has become an indication for transfusion for us. So for transfusion guidelines, there are two aspects to highlight. One is that there are patient characteristics that change what the recommendations are, and then there are product specifications. So in terms of patients, we were looking for essentially quality of life and growth in children. So you may need to individualize hemoglobin levels. Some patients do okay with 9, others need 10, and we have patients who would always want to be kept over 11. So there is an average where you start from, and then it needs to be tweaked and individualized based on the individual need. So in the splenomegaly, as I was saying, it's a prevention of splenic enlargement has actually become a goal of transfusion therapy. So you maintain enough hemoglobin and to keep the spleen suppressed. There is always the risk of elimination, of which we are very acutely conscious of. because of the red cell antigen disparity. So a genotype for red cell antigens is obtained in every case that we need, and it's kept on file by the blood bank. And then there are individual cases like heart failure, EMH, pulmonary hypertension, where transfusion targets may need to be even higher. But on the other side, there are RBC product and matching that also affects how we transfuse. So there is the issue of elimination, and there has been a movement where the donor centers that provide blood for a substantial number of chronically transfused patients can maintain donor registries that are genotyped. And so there is a ready access to match units, and especially to rare units, instead of having to screen a large number of units. The other challenge is the problem with the alloantibodies being evanescent and the screens becoming negative. It's even a bigger problem, I think, in thalassemia intermedia, but certainly for thalassemia major. If patients are moving between centers, then the risk of delayed hemolytic transfusion reaction comes up. And then the third thing is what kind of units we are selecting, because how many units you give actually does depend upon what is the hemoglobin increment after the transfusion and how long those transfused red cells are going to survive. So there's everything that we can do to select the best units that have higher hemoglobin content, so we don't use apheresis red cell units, for example. We prefer units that are less than 2 weeks old, and we recommend against irradiating red blood cells. So in the final part, I want to just mention that the actual recommendations come down to answering 3 questions: when to transfuse, how to transfuse, and what to transfuse. So this is distilling the background down to actual recommendations. In terms of answering when, we have usually we face with two different clinical scenarios. The first one is the infant presenting with severe anemia requires transfusions for survival, and this is kind of the prototypical patient that has served as the historical foundation for developing transfusion guidelines for thalassemia. These are the patients we recognize as beta thalassemia major, and many of them will be on transfusions by 6 months and majority by 12 months. So maybe we can assign like a 2-year as an age. If you're starting transfusions, regular transfusions below that, then you have beta thalassemia major. But if you don't need transfusions until you're 2 years old, like the patients we discussed, presented earlier, then you have some form of thalassemia intermedia. And in these cases, you're looking at a balance. Anemia, ineffective erythropoiesis on one side, and the complications of transfusions on the other side. And I think Dr. Pranter is going to go through this, so I'll skip it. But if you don't need transfusions right away, if you don't have thalassemia major, then what is it that will make you start transfusions? And then this is we're all familiar with these guidelines. How to transfuse, what's the target hemoglobin. The starting transfusion, hemoglobin is 10, but there are individuals with other forms of thalassemia that can do okay with lower transfusion numbers too, and some may need more. Frequency, we recommend 3 weeks for most cases, but younger children and thalassemia intermedia, 4 weeks is also okay. There are recommendations around what kind of how much blood to give each time, and for adults, In children, we are transfusing by volume, and in adults, we transfuse by units, and up to 4 units may be needed for the larger adults. And there are other volume considerations. For example, for most people, younger patients now have intact spleens, and they have higher transfusion needs routinely. And that's just something we accept, and we modify their chelation regimen accordingly. And then there is the recommendation for rate of transfusion, and this is also an individualized based on patient tolerance. And finally, what kind of blood product we are, of course, advocating strongly for pre-storage leukocyte reduction at source, so in the donor center. And the storage is almost universally has been adopted as the additive solution in the US, because these are antigen match units, so we prefer that they have longer shelf life than the CPD units. But when possible, we select units less than 2 weeks, and blood banks understand the need to do that for people on chronic transfusions. Many patients need washed red cell units to deal with allergic reactions. And then phenotypic matching is a big thing, because if you don't have any antibody, we would routinely match to the RHCE and KEL antigens. But if you have one or more alloantibodies, then there's an extended matching along with honoring the antibody that you are sensitized to. But many challenges still remain, and in the US especially. The expertise with thalassemia is concentrated in some metropolitan areas, and distance is a big problem for us. So we at least say that a hematologist has to either directly supervise or review the transfusion plan. And for all patients who are starting out on transfusions, there should be an open discussion with the family about curative therapies as soon as they're diagnosed, so that and then we still have a difficulty with many hospitals not adopting a thalassemia-specific transfusion protocol. We are partnering more and more with our transfusion medicine colleagues to have consistency and quality assessment, so that we can record the transfusion volumes, maintain antibody history, and now we're moving towards some form of a national database for chronically transfused patients who develop alloantibodies to reduce the risk of delayed hemolytic transfusion reactions. I thank you for your attention.
Thank you, sir, for that lucid discussion on transfusion, how transfusion guidelines have evolved in thalassemia major especially. And couple of points which I found it very true is that we constantly think of thalassemia as a disease of children, but that's not the case now. And as children are growing up, we need to have centers where we can transition these children to, and also need to have care plans planned out with the adult team also, which is something which we are constantly struggling. So your statement on a child is you're only a child for the first 2 decades of life was very true. And this is something which we need to factor in from the time the child starts, we start seeing these children. So we'll take questions at the end of the next session, sir. Together we'll take for both the sessions together. So now I would like to request Pranthir sir for his session on non-transfusion dependent thalassemia, how transfusion planning has changed.
Thank you. Thank you, Ash, for that nice, insightful, astute delivery. So what I'll try to do is, so I've been given the topic of transitioning from NTDT to TDT. We were talking of transitioning from the child to the adult. And let me tell you, when 70% of my patients, when they are diagnosed, have E-beta thalassemia, I think for me, the question that baffles me always is to transfuse or not transfuse. And I think when the parents ask me what would happen to the child in future, I actually frankly confess that I don't know. I need to observe that child for at least 6 months to a year. But if they present at a very early age, especially before 1 year of age, that there's a high possibility that they might need regular transfusion. So I think E beta thalassemia is a different ball game. And when you tell entity, it has a lot of entities, including the alpha variants and the traditional thalassemia intermediates. So I think for the younger audience, I would like to share the questions which baffle me even today. People like Ash and others have tried to provide answers to some of them, and some of them I think still needs a lot of research. So one question is why those labeled entity patients do not need blood transfusion. And what you will all understand is that there is no watershed divisions between this. So a person who is NTDT today can become TDT tomorrow, can become NTDT again. And that's why I think for us physicians, it is very important that we don't label a person like that. Because then there are problems in management, especially when they go to a peripheral center. If you have labeled them as an NTDT, then even when the person is deteriorating, they might not start a transfusion plan. There are problems with insurance and even with the policymakers. The next question, which still baffles me, is how do I diagnose an NTDT? So, the guidelines say, okay, you do a genotype, but genotype-phenotype correlation, in spite of looking at so many things, has not proven to be the ultimate holy grail. And that's why I think monitoring them clinically and watching the circumstances which under the patient is operating is equally important. And how do I become sure that it is an entity? Because once I label the person, which I told you not to do, but still we are compelled by certain regulations, legislations at time to do it, how can I be sure that it is non-transfusion dependent? Because I can tell you a story of one of the patients whom I was treating with E beta thalassemia, who was maintaining an average of 7.2, and then he did very well in his class 12 boards, and then took the SAT exam, landed in US. I do not know to which center he went, but he was told that your hemoglobin is less, you should be transfused. And that boy came back to us and said, I will carry on my studies in India because you were good, you were not transfusing. Now, these are the myths and these are the perplexities which still baffle me. And the question which is there in the mind of the patient as well as the treating physician is, will he or she become a TDT in future? Because there is ample data to show that as they approach adulthood, one is during growth and development, adolescence, and as they approach adulthood, there are a number of changes, be it in erythropoietin, hepcidin, and other modifiers, and they can become a TDT then. And then the question which I am always asked by those same patients is, now is it like taking insulin? Is it like being on an inhaler? Do I have to take transfusion throughout my life? And I am not the right person to answer these questions. Maybe Ash will help me at the end. But when I decided to discuss with you that, when does an NTDT become a TDT? I thought I'll go through these guidelines. There are also guidelines on management of alpha thalassemia. But because of constraint of time, today my discussion would be restricted to NTDT beta thalassemics, which are the maximum number of patients in my country and especially in Eastern Europe. So the first question, why are the NTDT patients not dependent on transfusion? You have heard a lot about the primary modifiers, the secondary modifiers, the tertiary modifiers. The most important thing is, and as Ash was highlighting, is ineffective erythropoiesis. And so if you co-inherit alpha thalassemia, and then your alpha is also low, that makes you a better person. And so some of the patients are fortunate enough to have reduced number of unpaired alpha chains, so there is less of precipitation. Obviously, the severity of beta chain mutation has its own effect, and there are more than 300 disease-causing mutations. So whether it is reduced level, that is we call, beta plus, or it is beta 0, and then what is the degree of imbalance? If there are increased alpha, it makes things worse. And if you have some co-inheritance of determinants of increased gamma chain production, especially some polymorphisms, or as you have HPFH mutations, then they can alter the disease. Now, my experience has been mostly with E beta, and as Shudito presented, I will also show you a family with 3 children, hopefully sharing the same genotype, which behave totally different. Now, what we all have to remember is that they are not dependent on transfusion. And as Ash mentioned, that nomenclature was more important because whom to include in a clinical trial, but they are not independent of transfusion. That means that you should not be so rigid that when they need a transfusion, this is an NTDT, we should not transfuse. This should not be the case, and I'll tell you why. So there have been a lot of publications. I have taken this from Musalam's paper in How I Treat in Blood. So if you look at heart, right? In TDT, as Ash mentioned, one is cardiac iron overload, the other is LV dysfunction. But in NTDT, one of the major features is pulmonary hypertension, which may increase with splenectomy, and preserved left ventricular ejection function, but right ventricular dysfunction and venous thrombosis. So you have some new players. If you're not looking for that, you'll be in trouble, because I've seen so many echocardiography reports. Yes, annual echocardiography has been done, but the only thing mentioned is normal ejection fraction, or sometimes maybe E by U. Nothing is mentioned about the tricuspid regurgitation velocity and other things. I'll come to that later. Now, endocrine and bone disease, you can have hypothyroidism, hypoparathyroidism, growth delay, all this in PDT, and that's why you have to be astute in deciding how much to transfuse. Bone disease remains a major issue in a person who has never been transfused also in NTDT patients. Liver fibrosis, cirrhosis is present in both, but as we were already taught that the iron deposition is different in the liver, but the management more or less remains the same, and you might see, if it is not picked up, hepatocellular carcinoma more in NT. This is what the epidemiology shows. But there are a host of other things which you do not see in the regularly transfused patients. Cholelithiasis, even in homozygous E, who are technically not NTDT, they are homozygous E. Extramedullary hematopoiesis leading to compression, neurological features, splenomegaly, and that splenomegaly, if it is not monitored, you will not understand the red. Silent cerebral ischemia, Ali Tahir and his group has shown it, that akin to sickle, you have multiple cerebral silent infarcts here, and leg ulcers, which we see a lot in our E beta thalassemia patients. Now, as far as anemia is concerned, if you are not transfusing, or so to say, borrowing the nomenclature from hemophilia, you are giving on-demand transfusion, then the sequelae of anemia with age, they keep on increasing. And maybe those reflect in the cardiac and the other manifestations. So what are the red flags? I think this is the core of what I'm speaking today. Symptomatic anemia. So you are saying patient has a hemoglobin of 7, but the patient has symptoms of fatigue, patient has shortness of breath on exertion. You evaluate it. If the patient is symptomatic, that is definitely a red flag for transfusing. But remember, there can be other comorbidities or conditions. So if you maintain a regular transfusion and the patient becomes asymptomatic, under monitoring, you can take them back to non-transfusion dependency. Growth delay in children. The case Shudipto showed us, the growth charts, those are so important. And for India, we have our own IAP Agarwal charts, which should be used. And then in adolescence, Tanner staging should also be done. And remember that height is more important than the weight for age. Pregnancy. I have seen at least 10% of the beta thalassemia carriers who decompensate during pregnancy. So they are not entities. And because of the physiological conditions of pregnancy and certain other factors, you might need transfusion during pregnancy. And here you're looking at 2 lives. So the growth of the fetus is equally important. You should be in constant communication with the obstetrician. They should not be worried. They are worried because of alloimmunization. And unfortunately, in India, red cell phenotyping is not a mass phenomena. It is not a standard of care. We are slowly trying to do it, and allo antibody screening should be a part of the program. And then pulmonary hypertension. I think I will spend some time on this, because if we do echocardiography, and I had my DM student doing a dissertation, we did not detect it in young, but as the age increases, you can detect it. Extramedullary hematopoiesis can be a medical emergency. So there, both transfusion and hydroxyurea, sometimes with a needle biopsy proof. We have even given local irradiation. But if you are monitoring your NTDT, the patients might not need those aggressive measures. Leg ulcers. If the patient is wearing trousers, we should make it a habit to take them up and notice the skin. Because sometimes the patients might not even tell you, because especially in our country, their threshold of complaining is far high. Hypercoagulable state, evidence of thrombosis, especially post-splenectomy, is a red flag, and you have to monitor not only to use hydroxyurea, but they might require transfusion. Heart failure. Now, this is obvious, and we do not want patients to go into heart failure. So when I work with my Sri Lankan colleagues, they always tell me, the patients only present to the ICU with heart failure. What can we do to prevent it? And I think in prevention, managing the iron overload and doing good quality echocardiography help us. Now, iron overload. You'll say, okay, iron overload, I'm worried. If I transition an NTDT to a TDT, it will increase. So that should not be an issue when you have such a good oral iron chelator today. I think that as the guidelines maintain, if the serum ferritin, if it's the only thing you have to monitor, if it is more than 800, but do not go by a single recording. And we know that especially in NTDT and in beta thalassemia, serum ferritin underestimates the iron overload. If you have a facility, you should do an MRI study every 12 to 24 months. But if you don't have it, at least go on doing serum ferritin every 3 months. Now, if there is iron overload, and if you have been a culprit, so-called, don't feel guilty about it at all, by putting the patient on transfusion. Just look at this part, right? So patients with NTDT more than 10 years of age, if liver iron concentration is more than 5 or serum ferritin is more than 800, you should start deferasirox, ideally 10 milligram per kg, and then depending on the response. But if it is very high, you can start with 20 also. And as I told you, MRI every 6 to 12 months is very difficult, but 12 to 24 months. ferritin every 3 months, dose escalation and 1 month. Now, what if it is low, right? If it is low, you keep on monitoring, and when you reach less than 3 or ferritin less than 300, then obviously you should de-escalate. So these patients, we have read multiple reviews. There is so much of evidence that without transfusion, they have iron overload because of the defective hepcidin pathway, because of increased iron absorption. Now you look at the left of the screen. Hemoglobin less than 10. Well, there are so many patients of ours whose hemoglobin is less than 7 or 6, they do not turn up to the hospital, right? But what we have to look at if they come to us, right? So symptom or anemia related morbidities, and then we have interventions to manage short-term and prevent long-term symptoms or morbidities. So I've told you the red flags. Now, if patients are older than 18 years and they are rich, that means they can afford luspatercept, you can try it. Otherwise, blood transfusion, then also keeping an eye that you are using complete blood group phenotype, looking for alloantibodies if you have started transfusion late, and looking for secondary iron overload. Hydroxyurea, patients with XMN1 polymorphism or LEPOR or delta beta, but frankly speaking, in E beta, unless they are frankly transfusion dependent, in our center, we try hydroxyurea for 6 months in such patients. If there is a clinical trial, again, unfortunately, we being the powerhouse of thalassemia, we have very few clinical trials with the novel agents till now. And then these are all there, which should be on your wall, and they should be conveyed to the patients also. So in a study, it has been proven that the average consultation time in India, if you take all clinics, primary health centers and the corporate hospitals together, is less than 2 minutes. So you might forget. It is better to have a checklist, better to have either a patient ambassador or a counselor or an advocate who checks these things are being done or not. Even BMD has to be monitored every 24 months. And as I told you, skin inspection is very important. Now, coming to the consensus issue of pulmonary hypertension. How far will you go to look for pulmonary hypertension, right? You should at least go in for an annual echocardiography, especially after 10 years of age, because pediatric echocardiography, the human resources are limited. And if you look at the TIF guidelines, they say patients with thalassemia intermedia or E beta thalassemia, all adult patients, splenectomized patients who have never been transfused or minimally transfused, who have elevated platelet counts, right? Patients with elevated NRBCs. And for that, you need to see that you're getting the corrected TLC count, because so many times in tier 2 or tier 3 cities, I have seen report mentioning all those NRBCs as white cells. Patients with a hemoglobin level less than 9 or elevated markers of hemolysis, right? Patients with iron overload, history of thrombosis, and with other conventional risk factors for pulmonary hypertension, which have all been listed in the guidelines. Now, why does pulmonary hypertension occur more in NTD, right? If you remove the spleen, that adds to it. There is iron overload. With age, it increases. Lack of transfusion actually contributes to it. Previous history of thromboembolism and a low hemoglobin less than 10 contributes to it. And those NRBCs in the circulation all contribute. But remember, whoever is doing the echocardiography, they have to look at the TRV jet, right? And if the TRV jet is more than 3.2, it is recommended that you should do a right heart catheterization and VQ scan. Now, that cannot be a standard of care in India, unfortunately. But nowadays, there are certain other protocols. You can talk to your cardiologist. They look at tissue Dopplers and other things, and they can tell you whether there is evidence of pulmonary hypertension or not. And those who are in the gray area, whether they're symptomatic or not is very important. But if the patient has anemia, it is very difficult to decide whether that symptom is due to anemia or due to pulmonary hypertension. Please get a cardiologist who is interested in the care of thalassemia in your team, and you can think of novel things, including machine learning and other parameters, to solve the problem of pulmonary hypertension. Now you might ask me, okay, how many of the entities will eventually become TGTs? There was a paper presented as a poster in last year's ASH. There they showed that the transformation rate was 41%. But the total number of NTDT patients was 34, right? And there were only 2 hemoglobin E beta thalassemia patients. They had also alpha, they had also intermediate. But what they found out in the real world, in the clinic, was the reason for initiating regular blood transfusion. And remember, these are not isolated. So all patients had fatigue, which was one of the indications. There was 32% patients having extramedullary hematopoiesis. Hemoglobin was less than 7, and their protocol was to start transfusion, and that was 8%. So not the hemoglobin alone actually mandated it. And then pulmonary hypertension was present in 15%. Now, if I talk of E beta thalassemia, you can all go through this article published in Lancet Global Health in 2021 from Professor Weatherall's team along with Nancy and Anuja, and you'll understand how different every patient is, because they also tried to stop transfusion. In fact, in this cohort, very few patients were on regular transfusion, but a lot of them had undergone splenectomy. And what we saw in Sri Lanka was, in spite of splenectomy, there was a significant number of people who still needed transfusion. So we should not think splenectomy as a cure-all kind of thing. It has to be an individualized decision. As far as hydroxyurea is concerned, you'll be amazed to know, I do not know, I reviewed the literature about 6 months back. Till then, the Cochrane said that ours was the only randomized controlled trial, which we had published more than 10 years back, where we saw 10 milligram per kg was doing well, even 5 was doing well. Now the standard is that you start at 10 and you go to the maximum tolerated dose. For people like us who never had a trial of luspatercept or similar molecules with us, we tried thalidomide under a clinical trial setting, and this is what we published, and it was working in a group of patients. There are similar studies from China, and if you want to look at our neighboring country, there is even a publication from Pakistan in combining hydroxyurea and thalidomide. But till to date, they can be only used in a clinical trial setting because they need monitoring. And we have seen constipation developing in a lot of adults. And another important thing is thyroid dysfunction. And in spite of low dose aspirin use, we have seen deep vein thrombosis. But this is what we do because it is affordable. Now coming to, if we look at the family physician setting, right? So sometimes the patients are not diagnosed and they are managed with transfusion alone. So this was actually advocated by VIP in 2013. It has been included in the guidelines also, that there should be at least a complete workup. You know, sometimes even iron deficiency is misdiagnosed. And if you do not have this hemoglobin typing and DNA analysis, please refer it to a hematologist or a thalassemia center when it is our duty. It is not that we are the best. We are still learning. But I think by looking at the patient and the data and monitoring them, we can do a better job. Now, this patient, I have taken her permission. Let me tell her story. She is 14 years old. She is in class 9. Her height and weight are all between 50th and 75th percentile. She has had normal menarche and her liver iron MRI and cardiac iron MRI showed normal values. She has been on hydroxyurea since 4 years of age, and currently the dose is only 5 milligram per kg. Her average hemoglobin is 7 to 7.2. She plays in a school football team. She is also a good swimmer and she usually stands first in class. But I still do not know whether I am doing the right thing. So I'm sharing it with you and we can discuss. Right? We could not even trace his parents. He is adopted. He is E beta thalassemia, and we tried hydroxyurea. The spleen was increasing in size. Then, under a clinical trial where people above 8 years of age were being treated with thalidomide, very low dose, along with low dose aspirin, we started it. The spleen has regressed. The spleen now is 2 centimeter palpable. His height is between 10th and 25th percentile. His weight is between 25th and 50th percentile. And his mother is afraid that I will start transfusion. I am monitoring the child. I've told them what the red flags are, and still I do not know whether I am doing the right thing or not. So maybe we'll discuss when we discuss Shudipto's cases. Another thing which is not even described well in the guidelines is what is the psychological impact if I switch an NTDT to regular transfusion? What happens to the patient? What happens to the family? And then if you talk of logistics, when even the TDTs are sometimes being transfused, but average hemoglobin of them is 7, because there is a gap of more than 100,000 units, at least in my state. So then you tell them that you will need regular transfusion. Maybe we have seen the echocardiography, and we have even under a dissertation done right heart catheterization. I think this impact on the parents and the child and even the adult is something we should look at. So this is a visual abstract where, Saliba, Musallam, and Tahir have discussed that there are certain issues, how you diagnose them, how you manage those who do not have clinical morbidity. I showed you some of them. How do you manage the anemia and ineffective erythropoiesis? And I think a lot needs to be learned, especially in E beta thalassemia. So Ash mentioned about clinical trials. So there are 2 types of clinical trials now, right? Fortunately, we will have some clinical trials in India also with those small molecules, which are tyrosine kinase activators. Now, within the NTDT, you have non-transfused NTDT, you have occasionally transfused NTDT, and you have frequently transfused NTDT, right? And these, when they become TDT, you can call them neo-TDT, right? That's a good thing. And if you can gain independence by clinical trials of novel therapies for TDT patients which target transfusion requirement, they can become ex-TDT, right? So this is what we are trying to do. And I think when more and more patients are on clinical trials, this is from a letter to the editor in American Journal of Hematology, 10 years after the nomenclature was discovered. So Shudipto mentioned about 2 siblings. I told you of a family, 3 sisters, all E beta. She needed transfusion once in 2 years. She needed transfusion once in 6 months. And she needed transfusion every 3 months. I have shown you this because this was the opening slide of my discussion on thalassemia intermedia 20 years back. At least I can tell you, 20 years down the line, I am still not very sure why this happens. There have been some hypotheses on HLA polymorphisms, splenic activities, and other things. And we still learn from this family. And the girl actually, which needed the least transfusion, she also had the least complications. So we thought that because she is an entity, she might have all those things which we have learned of, but she didn't have. I do not have the answer. Now I hand it over to Ash. Thank you so much.
Thank you, sir. We have Dr. Androla also joined on the call. I think she's in an airport, so she couldn't speak to us directly, but happy to meet you. So we will take up the questions from the cases first and then from the audience. So I'm just projecting those slides again. Yeah, so this again to remind the audience. So this was our first case where Dr. Sudipto had presented earlier. That this was a boy who was diagnosed as non-transfusion dependent thalassemia. He's started on hydroxyurea at the age of 5 years in 2017, and he's had only one transfusion till then. He's growing okay. His weight is above, so his hemoglobin is above 8, and he's growing okay in terms of height is okay, weight is not so much, and his cardiac as well as liver MRI seems to be okay so far. So he's not on any chelation currently. So now that he's 12 years, the question was till the time he is 18, is there any significance? Do we continue the same or do we need to transfuse him? Because he's okay as far as height, but weight is still on the lower side and he has slight hemolytic facies, which the parents seem to be okay with. So I think we are currently treating him the same way. So I would request opinion from the audience as to how, as an opinion from the experts as to how they would manage the same or differently. Dr. Lal and Dr. Chakrabarti.
I think Ash can start the ball rolling.
Yeah, so this is, I don't think any of these cases are straightforward. That's why they're being presented. So to be objective about these kind of decisions, we have listed out the criteria for starting transfusions. And my sense is that this child does not meet those criteria at this stage. The one thing I would watch out for is pubertal delay, which I think is all very likely to happen. And though I don't think it will be pubertal failure, I think it will be a pubertal delay. And that can be an issue for psychological reasons when other children in the same class and same grade are growing rapidly during puberty. So we try to actively manage, be a little proactive about that in counseling and so on, and let them know that their time will come. They will grow late, but they will grow. But I think if there's a real concern about any of the physiological parameters that Hunter has described in great detail, if any of those are met, then yes, we would transition to transfusions. But at this stage, Hunter, I don't know if you feel otherwise. I don't seem like it needs to be transfused.
We just need that.
So
So
I
we,
completely agree with
Dr.
you.
Chakrabarti,
And I
yes.
think sometimes, as you rightly mentioned, that, yeah.
Did we lose Dr. Prantha? Am I audible, Manisha?
Yes. I think Dr. Pranther is
Signal is
his signal is lost.
Yes, sir. So
Yeah,
you're
yeah,
back.
I'm back. Yeah. So I completely agree with Ash. And, as he rightly pointed out, that the family and the boy should know about pubertal delay. And not only we are proactive, they should also be proactive in following up with us. And then we take the decision as we cross the river.
Okay, sir. So now going to the second case, which is slightly more difficult. As in now he is 14 years. So this is a boy who has been managed so far as NTDT with a massive spleen, short stature, a, a significant hemolytic facies. He's been on hydroxyurea, never been as in transfused very occasionally. And he has iron overload in the liver. So now this was the first, this is a question actually which was not projected earlier. But in such a scenario, when there is no ferritin is still below the cutoff, but your liver iron is still there, you would start on chelation, right? So this is straightforward. And then we started him on transfusion. So it's been only a couple of months now, but still there is no significant, like 6 months have passed, no significant difference in the spleen size. So as you would agree, when there's a massive spleen, it's often difficult to get it regressed. If you're trying to transfuse also, it's quite difficult. And even the hemoglobin also, we've never been able to achieve a hemoglobin which is good enough for the spleen to start regressing. So in such a scenario, at your centers, would you start them on new agents? And when would you actually consider splenectomy in this child who is at very high risk of a thrombotic tendency?
I'll take the risk of going first before Franca. So I think for us, this child was probably never NTDT.
Yeah.
We would have started transfusions. We do see such cases. I think one of a significant proportion of my patients are those who are refugees from conflict areas in the world. And they have much worse care than even some of the cases that I've seen in India. They have there's been difficulty accessing blood, and there's no way that anybody's been ever evaluated for iron overload or been given any. So I do have, but I think for this patient, the criteria for sometimes that is helpful just to have the table in front of you and say, well, this is the consensus that if your spleen is rapidly enlarging during childhood, the outcome isn't, that's just telling you that the disease is severe. Even if your hemoglobin is above 7 or it's 7.2 or 7.5, if your spleen's getting bigger, then it's headed towards a situation where the condition is going to present with severe symptoms later. So like the case I presented where we started transfusions on a child at 7 years and the spleen regressed. She's now 16, 17 years old, and she's taller than her parents and all. That's the usual thing. So that I think that we have to be. It's the question of TDT and TDT. It's become more bothersome as time has gone by. I feel like unless you're considering putting a patient in a clinical trial, don't use those terms. Just say this patient has beta thalassemia or E-beta thalassemia. Is it major or is it intermediate? If it's intermediate, then you need to monitor them at least every 6 months and see if they're meeting any criteria to start on transfusion. Then if they do, then parents have to be counseled and they have to get on transfusions.
And regarding spleen, would you remove a spleen and because he fits criteria for a splenectomy?
So what I would do for my patient in San Francisco, we would not take the spleen out. We would hypertransfuse. We will bring the family back every 7 to 10 days until we can get the hemoglobin up over 10 or 11 and then try to maintain it. That's what we've done, and we've been able to do that in some patients for over a decade. But that requires hypertransfusion, that requires combination chelation therapy. You get into a whole different world of intensive thalassemia management. That requires so many resources that I'm not, I wouldn't advocate doing. You really need very close monitoring, because you need combination chelation therapy for sure. You can't manage these patients if you put them on hypertransfusions with hypersplenism that they have. Then a single agent is never going to be enough for chelation.
Yes, Dr. Prantha?
Yeah, so I agree. I mean, the time was when the spleen was increasing, because I think there's a golden period of opportunity when the spleen is increasing and you put it on a regular transfusion regime, the spleen regresses. And we often see such patients where the kind of transfusion support we can give, we cannot get the spleen to regress, and there's an element of hypersplenism. Now, whether I would splenectomize or not would definitely depend on how this boy is doing, right? Because we know splenectomy has its own problems. Other than OPSI, it's also about pulmonary hypertension and a host of other issues. But if you cannot transfuse, right? Transfuse the to at least maintain his oxygenation, right? At least his basal metabolic rate so he can do his daily activities, then I would suggest that we can try, but not with high hopes that this patient will improve dramatically after spleen. But I keep it as a last resort. But obviously, as Ash has rightly mentioned, you cannot going for we going for combined chelation sometimes, but those are in patients who were poorly chelated in their childhood. But for such patients, giving so much blood, managing iron overload, and a host of other issues, when others are also suffering and you always have to ration your resources, I would try to get splenectomy done, explaining everything to the patient and the family, and also taking opinion of my colleagues.
Can I just add something to that, project?
Yeah, please, Ash.
So we do splenectomize patients occasionally, and especially adults, where we can't even maintain a 2-week interval between transfusions because they're using up the bloods that quickly. What I would say to my patients is that doing a splenectomy is not going to convert the patient back into NTDT. I think that's where the biggest fallacy to me is, that if we stop transfusions after a splenectomy, you haven't changed the pathophysiology of the disease. The thalassemia was severe to begin with. And these are the patients who present after 10, 20, 30 years with all of the severe complications that Ali Taher and Musallam's papers have pointed out, which include cerebrovascular disease, pulmonary hypertension, leg ulcers, and multiple fractures. These are exactly the patients who will present after a few decades with irreversible complications. So taking the spleen out will only make it easier to transfuse the patient and to take care of the iron. But I don't think that this patient should be left without transfusions following a splenectomy.
Totally agree with you. Yeah.
Thank you, sir. So now to the next part of that case, actually. So he has a sibling. So like Dr. Prantha showed, this is younger sister who was just accompanied the child for when her brother was being shown, and she was picked up to have the same disease, as in she has moderate anemia, splenomegaly, HPLC suggestive, and high HbF, and she is growing okay. And so her hemoglobin was around 7 to 8, and then she was started on hydroxyurea. She's maintaining well. So how do we explain this variability in presentation? And she's never been transfused till now. And what do we expect for her? Like at some point, if we keep her on hydroxyurea, is that good enough, or do we say as she has a growth spurt later, or when she goes a pregnancy, she will probably require transfusions at that time also, right? You are muted, Sahan.
Brother, go ahead, please. Yes.
No, I do not know. I only know that, genotype is only a part of the picture. And as I told you, how the body deals with it, how the spleen behaves. And as there have been some publications also from our group regarding some HLA polymorphisms and other things. But this is the beauty, I think, of looking at thalassemia patients, that if you clinically monitor them, everybody is different. And you can tell. So I was discussing this with Professor Weatherall also, and I remember what he told me. He said, you are saying genotypically same. You're only talking about a beta globin gene mutation. What about the others? And obviously, you know now that there are so many things going on. And we do not know. I think Ash is in a better position to do research on this. But if you ask me what to do with this patient is, just like in the first patient we had, we will keep on monitoring her and we will take decisions as the time comes and as we see what she's doing, how she's doing.
Thank you.
Right. I think the the question, and this is a very obviously the phenotypic variability is one of the biggest subjects in thalassemia, which I don't think anybody in the world will claim to be an expert in that. There, we recognize the the variability to rise from both globin gene mutations and then things that are outside of that. In siblings, we can expect the haplotypes to be identical. But as Pranthar is saying it, that's only the globin gene. So the XMN polymorphisms are likely to be the same are going to be the same in both the patients. They're so proximate. But what may differ is the other quantitative trait loci, which are outside of that. So whether it's the BCL11A or the HMIP, that, and there may be other yet unknown factors that modify the ability to express gamma gene after birth. And that is one of the bigger reasons why patients differ. And I think what the most illustrative articles on this have come from Italy, where patients with the homozygous beta 0 mutations, many of them did not need transfusions because they continue to make a very high level of fetal hemoglobin. And the reason was traced to these QTLs that I was, the quantitative trait loci that I was talking about. And eventually, even if we don't have it yet, but we hope eventually that when we say we want to do a genetic diagnosis of thalassemia, we will not only test the beta globin mutation, but we do beta, we do alpha, we do the gamma promoter, and we do the QTLs, all the known QTLs at the same time in one NGS assay. That's your thalassemia genotypic diagnosis, not just the mutation that you have. But we are currently very limited if you're only given the mutation itself and not what's affecting. And that's only the genetic things. But I think in Sri Lanka especially, I think in other places, the environmental variables are the other things that we're not totally sure about. So whether that's malaria or whether there are other reasons where there might be an early splenic enlargement, but then just snowballs into more and more hemolysis and other things. And we've observed that, and we were doing some collaboration in one of the Southeast Asian countries where our patients with alpha thalassemia, very few of them are on transfusions, but at a center in one country, more than half of the patients were on transfusions because they had massive spleens and exactly the same globin gene mutation. But so I think majority of the things are genetic, but there are also environmental variables.
Thank you, sir. And quickly for the third case, which is because we are already short of time. So this again is this is a 9-year-old girl. She has been managed as NTDT till now, but so she's again one of 3 siblings with thalassemia. again, small children. The other ones also are managed as NTDT. But then somehow they did not have any of these complaints. So she came to us recently with difficulty in breathing and climbing stairs. And echocardiography picked up a pulmonary hypertension with TR. And since then, she's been on sildenafil, and she's been advised to shift to regular transfusion. So they're from around 200 kilometers away from our center. So they're continuing transfusions there, not very regularly, but yes, they are being transfused more regularly than before. So my question was, how long do we continue? So this is a complication where we do not reverse, like in the growth of puberty, we have an option of stopping it after a while. So how long would you continue in such a patient? Is this lifelong transfusions that we're looking, or if the cardiac function improves, do we have the liberty to go back to intermittent transfusions?
Prantha, you want to speak on the pulmonary hypertension?
No, I do not have much experience, so you'd be better.
So is that a single echocardiogram finding?
Two echocardiography. So this actually we couldn't trace the earlier one because she's not available recently. So this is the second one. The earlier one was a little worse. That's what the cardiologist remembers.
Okay. I would think that this seems like a borderline. I wouldn't.
So this has improved. So that's what he also said, that this has improved on treatment. So we don't have the original numbers.
It probably doesn't qualify for a right heart cath, given those numbers. But I would say that this patient probably needs to be on transfusions for other reasons, not for pulmonary hypertension.
I missed you. You would transfuse for life, for continue transfusions for life?
Yeah, not necessarily for pulmonary hypertension, but I think it just seems like a severe thalassemia anyway, from other features.
Okay, sir. Dr. Prantha, any suggestions?
No. So I think, is she was on hydroxyurea and now she's on sildenafil, right? So what I would think is that also to get a cardiologist on board and go on doing it. But I agree with Ash that maybe she is a TDT from the beginning, and what we are seeing is partly due to the anemia which was not corrected and partly due to this. So if she is improving, if her symptoms are improving with regular transfusion, she should be on regular transfusion.
Yes. So the second and the third children. So we see a lot of kids like that who've been managed till the age of 7-8 years as NTDT, and then they suddenly, when other things come up, they get referred. So maybe they were not NTDT to begin with. Yeah. So this brings me to the next question, which is in the chat box from Dr. Anand Prakash from Bangalore. So he wants to know, once a patient, when we transition them from NTDT to TDT, what happens to the hydroxyurea? Is there any role in continuing hydroxyurea in these children?
Well, the only one specific indication that we continue hydroxyurea is when transfusions are started for extramedullary hematopoiesis. In most other cases, we are trying to suppress the bone marrow with transfusion with adequate hemoglobin. And that's not a situation where hydroxyurea works very well. It requires some marrow stress to produce its best effect. So we usually we will not keep the two together, but I've seen being done in many places. That's fine too. If you think it has an effect on the total transfusion needs, then perhaps you could continue it. But that we usually don't do the two together.
For our center, actually, what we do is, if someone does not have a very, within the TDT also, it depends on the frequency of transfusion. Now, when we start regularly transfusing and we see that it is a fairly regular transfusion, then we do not continue hydroxyurea. But it is regular, but still not that frequent. We sometimes continue. We do not know what it does, but theoretically, what Ash has said is absolutely correct. that it best works when we are not transfused.
Yes, sir. So the next question is why, from Dr. Suganya, why is pulmonary arterial hypertension more common in NTDT than TDT?
Oh, there's been a lot said on that topic, and it has to. So in beta thalassemia, it's more arterial, and the hypercoagulability and red cell membrane damage and endothelial damage are the things that play a part in it. And it's potentially preventable for that reason by even by giving aspirin. It seems to maybe reduce the risk of pulmonary hypertension. But so that's why it's more common in splenectomized patients who are not being transfused, is because all of the cells, red cells, are endogenous red cells that have membrane abnormalities, and they interact with the endothelium, and there's also hypercoagulability from high platelet count and those.
And even there's some amount of nitric oxide depletion we have seen in sickle also. So there are a number of factors actually. So when you transfuse, you give normal cells. If you try to make it very simple, these abnormal cells can more predispose to endothelial dysfunction and vascular.
So how would hydroxyurea help? It's still bringing up endogenous.
Yeah, but hydroxyurea also has a nitric oxide donating capability, which has been proven in certain studies, and it may also contribute to endothelial function, because even if I take the example from the Impian world, in essential thrombocythemia also, it plays a role in decreasing them. But I am not a bench scientist, so I cannot tell you all the mechanisms. This is what I know.
Thank you, sir. Another question from Dr. Prachi Jain. I think this is the second, two more questions after this. So when to start and subsequently stop transfusions in NTDT with primary amenorrhea and TANA stage 1 for a child who is aged 16 years now?
Well, so I apologize. I don't think there's enough information for me to say it one or the other. I would, I think the first thing we would do is an endocrinology consultation in these cases, and then look at the set of criteria, whether the child actually meets. So if there's no endocrine reason for the amenorrhea, then yes, could potentially be a reason to even try transfusion. But I don't know what the baseline hemoglobin level is, what the growth has been so far, what is the bone age, So there are many other things. What's the family history of people onset? And so I would start in these cases. We always start with an endocrinology consultation, and then decide based on that whether thalassemia is the likely reason.
Sir, sorry, can I add on the information that you just asked?
Yes, sure.
Yeah, so endocrine evaluation has been done in this child, and the most likely cause is because of the iron deposition, because of the thalassemia per se, that she's having these things. And the parents have come to us now because now the child has started to feel that her peer groups, her other friends, are like she's different from other friends, and that is why they've come. So what should we do?
Sure. So iron overload, you mean in a non-transfused, the patient has never been transfused, right?
She has never been transfused till now, yes.
I think it's a little unusual.
Like around 8 with hydroxyurea.
Yeah, it's slightly unusual for endocrine failure like this to happen in non-transfused patients because they tend not to have a lot of extra hepatic iron. So one thing to just to figure it out is to do a pituitary MRI if one of the neurocenters can do an R2 and look at the pituitary. And I think that would be the definitive answer, whether there's iron deposition there or not. But
Oh.
the response then, if it's from thalassemia, is that you would try 1 or 2 years of transfusions to see if you can move things along.
Thank
Okay,
you.
thank you.
Another question. If a patient has had history of thrombosis and has been splenectomized, hemoglobin around 10 on hydroxyurea with elevated WBC count and platelet, should the patient, and he is on ecosprin as well as anticoagulation, should the patient be on regular transfusion or occasional transfusion? And again, I think the question is not very clear. So if Dr. Jatin is on the call, you can unmute and discuss.
Matthew, please go ahead.
Yeah, I think so. The thing is, what kind of thrombosis occurred, and so because you are giving both antiplatelets and anticoagulants already, and you said the hemoglobin is 10 and patient is splenectomized. Was that right?
Yeah,
Okay.
that's what's written.
Okay.
Presuming it's NTDT splenectomized with a history of thrombosis on hydroxyurea, patient has a hemoglobin of around 10.
Right. Well, firstly, before thinking of transfusion, I would look at why this child got because whether there were other risk factors for thrombosis, that would be one of the approaches. Because if someone is maintaining that, then why what was the mean hemoglobin level prior to splenectomy? Is the question there?
No reply yet. So let's go to the next question for shortage of time. So
Yeah.
from Dr. Priyanka Chauhan, how long should we continue thalidomide and hydroxyurea if patient responds to the same? Should we taper and then stop? And what will be the long-term effects of the same? We have experience of long-term use of thalidomide in adults in myeloma setting, but not in children.
Yeah. So in children, obviously, the safety again is there. Even in adults, we always say that it should be under a clinical trial setting, right? Because hydroxyurea, it has been used for more than 20 years in sickle and other conditions. Even in thalassemics, there are a group who have been done it. So we know about the safety. Thalidomide does not have that kind of a safety profile. But if it is working, and then when do you stop it? It's $1 million question, because once you stop it, you will obviously not be getting the benefits whatever it was providing, be it in the rise in fetal hemoglobin, the hemoglobin level, or suppressing the marrow, or decreasing the spleen size. So I have had patients on hydroxyurea for more than 15 years, and unless something has happened, like in 1 or 2 cases I saw in the later half, they were persistently having leukopenia. So we adjusted the dose there, but we usually do not stop hydroxyurea if it is working and if it has met whatever our target was. Ash, what would be your opinion?
So I don't have any experience with thalidomide, but hydroxyurea is for sickle cell, as you know, it's a lifetime medication. It started right around when the child turns 1 year old, and it's given throughout life. So I think the safety concerns with hydroxyurea outside of the malignant, pre-malignant settings that it is, or MPN settings, that there really have not turned out to be any safety concerns with hydroxyurea. It's been a great drug for sickle cell, and I think if it works in some patients with thalassemia, it should definitely be used.
Thank you, sir. So I think we finished today's session. Thank you again to both of you for that wonderful talks and for the discussion that followed and for answering each one of our questions. And so I would request Deepak Chopra ji to kindly give your concluding remarks. And before I sign out, so the next session will be on 30th of November. So again, that's the last Saturday of November. And we'll be discussing blood safety this time in a setting of transfusion dependent patients. We have two speakers. The international speaker is Dr. Erica Wood. She is from Monash University. And the national speaker is Professor R.R. Sharma from PGI Chandigarh. So over to you, Deepak ji.
I'm extremely grateful to Dr. Ashutosh Lal, who I think is still on a Saturday morning, whereas we are going into our pre-Diwali celebrations here. Thank you, Dr. Lal, for such an educative, informative references which you had will be very, very useful to all the doctors who are on this particular webinar. Dr. Chakravarti, you are a known eminent personality from within the country. I'm sure many of the faces and many of the persons who are attending the webinar have been your colleagues or have been consulting you off and on. All the information which you shared and the guide that you have been to many of us over here is always going to be very, very useful. As I had initially said, that in our half a century journey, a lot of the children have now become adults. They are adult thalassemics. So I would request Neetaji, when she's planning the next of the sessions, if she could also think of bifurcating the session, that part one of the session be for those who are below 18 and the second part of the session be for those who are above 18, because the issues and problems as well as the management structure is also quite different for those who are below 18 and for those who are above 18. The other aspect is, which I must bring to the notice of persons like Dr. Ashutosh Lal, that, over here in India, we have very few references available for those who are now crossed 50 years of age. Fortunately, we have some thalassemics in certain cities like Delhi, Mumbai, and down south also, who have crossed 50 years of age. So their issues are quite different, and we don't have very many references here. So it would be of great help if eminent personalities like you, who are seeing patients and have knowledge of patients who are above the age of 50 or around that age group, as to how are those issues being handled pertaining to osteoporosis of bones, as well as other natural daily duties concerned. So with these words, Neetaji, I am really grateful for you, for having organized, curated this sort of a webinar, and also to ECO for giving us a wonderful platform for this sort of a webinar. Once again, thank you all who participated. I think the maximum number I saw on the screen went up to about 120. So I'm sure your next session will have many more participants. With these words, I wish you all and your families a very happy Diwali. Thank you.
Thank you. Happy Diwali to all.